Hello, and welcome to this RPTH research recap, where we dive a little deeper into the science that's being published at RPTH. My name is Jeffrey Barnes. I'm a member of the RPTH editorial board. I'm a cardiologist, vascular medicine specialist, and health services researcher at the University of Michigan in the United States. I'm very pleased to introduce Ms. Victoria Speed. Victoria is currently a specialist anticoagulation pharmacist at King's Thrombosis Center at King's College Hospital in London. Her interests involve investigating the safety, efficacy, and population pharmacokinetic modeling of Rivaroxaban in clinical use. She will be defending her PhD very soon, and this paper has been a central part of that work. The paper that we're going to be discussing today that's been published in RPTH is titled Rivaroxaban in Acute Venous Thromboembolism, the UK Prescribing Experience. I'm really excited to hear from her on this excellent summary of Rivaroxaban's use in this important clinical population. Victoria, I'd love to hear your presentation.
So yes, thank you for the introduction. So I'm going to be talking about the results of the first registry, which was a registry study in the UK looking at the safety and efficacy of Rivaroxaban. So thinking back to 2013, 2014, when the registry first opened, it opened shortly after the approval of Rivaroxaban in the UK. And we wanted to do this study to really investigate the use of Rivaroxaban in clinical practice. 2013, 2014, we were still getting used to the idea of one dose of Rivaroxaban really suiting everybody, coming from a background of using warfarin, for example. And then how safe and effective is Rivaroxaban outside the rigor of a clinical trial without all the monitoring and the close follow-up? So the aim of our study was to investigate the safety and efficacy of Rivaroxaban in daily care in the UK. So we had a very straightforward design. So it was a follow-up study, a prospective UK-only multi-centre non-interventional study, and we followed up our participants for up to 5 years. The inclusion criteria was also very straightforward. So patients needed to have an objective diagnosis of VTE and to be treated with Rivaroxaban. The exclusion criteria, now we really wanted to capture patients treated upfront with Rivaroxaban. So we allowed no more than 48 hours of an alternative anticoagulant prior to starting Rivaroxaban. The participants needed to be able to be followed up, and there could be no alternative indications for anticoagulation. So in order to get our external sites, the first registry was part of the UK National Institute of Healthcare Research portfolio, which means we could put a call out for external sites to express an interest in participating, and that's how we got the rest of the sites on board. Data collection was also a very straightforward format, and we wanted to coincide our study visits with the local follow-up pathways at our external sites and indeed our own site. So the anticipated points of contact were 1 month, 3 months, 6 months, and then annually. Visits could be face-to-face if the patient was in the hospital, or by phone. And all our data was held on a web-based server. So all the sites input their data directly onto the server for us. The primary efficacy outcome was the incidence of objectively diagnosed recurrent VTE, symptomatic recurrent VTE. And the primary safety outcome was the incidence of major, or the first treatment emergent, major or clinically relevant non-major bleeding. We use the ISTH definitions for the assessment of severity. So to the results. So between 2014 and 2018, we recruited 1,262 participants from all over England, and 1,239 were in the safety population. And the safety population was anybody that had received 1 or more doses of Rivaroxaban. And we recruited from 22 different NHS, so National Health Service hospitals around England. So we went as far north as Newcastle, as far west as the Welsh borders, and over to my own home city of Lincoln in the east of England. Participants, who did we recruit? Well, we were really pleased that we had such a variety of participants within the registry, and we had patients that ranged from 18 to 95 years old. We had patients weighing between 35 and 234 kilograms, which we thought was quite something. And we had over 100 participants who met that ISTH threshold of 120 kilograms or a BMI over 40. So we had a good representation of that higher body weight cohort, which was really good. I should say that the majority of the population were white, and that should just be borne in mind if we're comparing or thinking about this data. In terms of index events, the majority of events were lower limb DVTs, and about 1 in 5 participants had a PE. About 3/4 of our index events were unprovoked, and we had 35 cases of cancer-associated VTE where Rivaroxaban was used up front, which was about 2.5%. Treatment-wise, generally really good in terms of being prescribed according to license. So 99% of patients getting 15 milligrams twice a day for those first 3 weeks, and then followed by the 20 milligrams for the maintenance dose. And we did manage to get 60% of our participants really treated upfront with Rivaroxaban with no interim doses of low molecular weight heparin, for example. So what happened to these patients? So the median duration of exposure with Rivaroxaban was 135 days. About a quarter of patients continued on long-term anticoagulation with Rivaroxaban, and the majority of patients ended their treatment as you might expect. Interestingly, 1 in 10 patients switched to an alternative anticoagulant, and the majority of those switches were due to a patient-reported adverse event. And a third of those adverse events were bleeding related, but actually quite a proportion were non-bleeding related side effects. And I think, well, certainly in practice, we often really think about the bleeding related complications, but actually for a lot of the first registry participants, they switched because of something that was non-bleeding related, and most commonly because of headaches, dizziness, nausea, so that sort of side effect causing them to switch. So now just thinking about the clinical outcomes, so our primary and safety and efficacy outcomes. So we had 7 episodes of recurrent VTE. 2 of those were adjudicated by the steering committee to be treatment failures because they had uninterrupted Rivaroxaban therapy. However, 5 out of the 7, during our root cause analysis, we saw that there was periods of interruption where the patient had missed doses for a variety of reasons. But in those 5 cases, they were felt to be due to non-adherence rather than a failure of Rivaroxaban. In the safety outcomes, we had about 1% major bleeding, which was 11 cases. And importantly, we had no deaths related to either VTE or indeed related to bleeding complications, which is good. So just going to focus a bit more on the bleeding now. The most frequently reported site of bleeding was abnormal vaginal bleeding, and that really is a main sort of finding of the paper. So it represented the majority of major bleeding, and of all bleeding events, there was 1 in 4 episodes. The second most frequently reported site of bleeding was macroscopic hematuria, and we typically saw these in older male patients. And just to go back to the abnormal vaginal bleeding, this typically manifested as heavy menstrual bleeding. Either the period was heavier or it lasted longer, and that's we saw this reported a lot. So just to go into that a little bit further, so we looked for the factors that were influencing our patients and who was most likely to experience bleeding. And what we've found, I think, is quite nicely described by these Kaplan-Meier curves. So if we look over at, well, both plots demonstrate the time to event analysis for clinically relevant non-major bleeding or major bleeding up to 1 year. And plot A is stratified by age and age 50. And you can see here a signal for more bleeding in the younger patients. But that's not the end of the story. And I think we already know that from if we look at the site of bleeding. So then if we look at the blue line and the green line on plot B, the blue line represents female patients under the age of 50, and the green line represents male patients under the age of 50. So the two younger groups of patients, you can really see a difference there with gender. So it's these younger female patients that are really experiencing significantly more bleeding. So it wouldn't be right to say it's younger patients, it's younger female patients that have the problem with the bleeding. And also we saw a slight trend for more bleeding in our older male patients, although it didn't reach significance. And I think we saw that coming through from that higher, from the frequency that the macroscopic hematuria was reported in our older male patients. So just sort of the main points from the study. So this was a big study of 1,200 patients prescribed Rivaroxaban in the UK. In the UK, we don't have a set format for how patients are followed up or where Rivaroxaban is prescribed. We've got cardiologists, hematologists, nurse practitioners, pharmacists prescribing Rivaroxaban for VTE. And I think what's really reassuring to see is that Rivaroxaban is highly effective in this population, albeit low risk. Rivaroxaban is safe for the majority of people and well tolerated, but there is a higher frequency of bleeding for women of childbearing age. Of our recurrent VTE cases, there was 5 cases that had an interruption or an issue with adherence. And I think that's something as healthcare providers we can definitely think about when we're counselling and following up our patients on Rivaroxaban. And on a similar note, 10% of patients switch to an alternative anticoagulant during their treatment. So again, that's something important to think about for healthcare providers to make sure that we're able to be contacted by our patients in case they've got any difficulties down the line. So the limitations of the first registry, well, it's a low-risk population, mainly because of the exclusion criteria. We include distal and upper limb VTE events, which should be borne in mind if comparing with Einstein, for example, where they only look at the proximal events. And it's a registry, it's not a clinical trial. So although we've tried our best with data cleanliness, it's a registry at the end of the day. And in conclusion, Rivaroxaban in the UK is highly effective for the treatment of VTE, and I think first really highlights the need for further research into the use of DOACs in women of childbearing age, and also for use in patients with a high thrombus burden and post-thrombolysis. So that's it. Thank you very much. I've got a long list of thank yous there, but mainly thank you to all of our participants for taking part.
Thank you, Victoria. That was a really great presentation. I wonder if I could ask a couple follow-up questions. You really highlighted the point that this was a registry-based study, and I do a lot of registry-based studies. I was impressed that you brought together 22 different centers. That's really quite a lot of work. Can you tell us, were the patients that you enrolled in the registry sequential patients, meaning every patient who had a VTE prescribed Rivaroxaban was enrolled, or is there opportunity that maybe some patients were selectively enrolled or not selectively enrolled? Is there any opportunity for bias there?
Yeah, that's a really good question, something that we've worked hard on to make sure when we're recruiting sites to take part in the study that Rivaroxaban is their first line treatment. But you're right, it's not a protocol-driven study. So if, and I think particularly as time elapsed, patients started, there's different trends in prescribing, so you might start to see more Apixaban coming in certain patient groups later in the study. But how we've tackled that, like I said, is by enrolling our recruiting centres as having Rivaroxaban as first-line treatment. We've got screening logs, of course, to see that we're getting sequential patients. So we've tried our best, but I definitely think maybe as time's gone on, it was open a long time, the study. So I think there's, as new data comes out about the use of other DOACs in other populations, there might have been creep later on, but I think we've got most sequential patients.
No, that's great. And as a follow-up, during that time period of the registry study, would you say the vast majority of patients with an acute DVT or PE were eventually put on Rivaroxaban? How many were maybe given warfarin therapy or other therapies? Do you have a sense for sort of how this population in the registry represents sort of the total acute VTE population receiving anticoagulation at these 22 centers?
Yeah, I think there's it varies between the centres. How much they stick to one anticoagulant and how much there's movement, because I think that Rivaroxaban is prescribed in so many different settings in first, inpatient, outpatient, emergency department. I think later on in the study that patients where we saw older patients or patients with poor renal function, maybe that more of patients would perhaps have received Apixaban. I think I've seen that in centres, including our own, as time's gone on. But yeah, I think on the whole, it paints a good, an accurate representation of practice at those 22 hospitals.
The other thing I was struck by is just how good a job these centers did at prescribing the package label recommended dosing. I actually found that to be quite impressive. And I'm wondering, was there any support mechanism built in at these hospitals? I mean, were pharmacists involved in this broadly, or was this sort of any doc, nurse practitioner, whomever could just prescribe the drug and they just all happened to do a great job at it?
I know it's true. Anybody was prescribing, not anybody, we had doctors, nurse prescribers, pharmacists, all prescribing the Rivaroxaban. We at our centre we used the pre-pack, so you've got 21 days and the 20 milligrams, so it's kind of all set up nicely for you, and they are quite a lot of the centres have quite rigid pathways, and of course there's a pharmacist check, a clinical check in the UK as standard on these sorts of things being dispensed. So yeah, I was pleased to see such a high quality, high standards of adherence to the prescribing guidelines, particularly as a pharmacist by trade.
Well, and as a physician, I always appreciate working with my pharmacists because they are just so knowledgeable about the nuances of these drugs and making sure that we as physicians in the United States are prescribing them appropriately. So I applaud you for that. I'd like to ask one last question, which is, you brought up the point of the two sort of types of bleeding, the abnormal vaginal bleeding, primarily in those younger women, and then the macroscopic hematuria in the older men. And I'm wondering, in the registry, did that lead to drug discontinuation across the board, or did you find most people switched to a different agent? What tended to happen when patients presented with those types of bleeds?
The heavy menstrual bleeding, or the abnormal vaginal bleeding, it was really interesting looking at that data, because what you saw is these women presenting quite late. So often they would present at their 3-month or their 6-month follow-up with really significant bleeding, and they've sort of soldiered on through this. And I mean, I've seen it in practice myself, and you think, oh gosh, I wish we'd done something different, or approached this differently, so that this patient didn't think that this needed to be normal for them. And so that's interesting that actually a lot of these cases presented later. Remind me of the question again. I've gone off on a tangent, perhaps.
No, that's perfect. I was just wondering how often they stopped their anticoagulant altogether versus switching to something else.
Most commonly, they switched. And they switched to Apixaban or low molecular weight heparin. Sometimes we saw maybe the use of the 10 milligram dose, particularly for those that are continuing, but a mixed bag. And I think that mixed bag of the approach of how to deal with this really demonstrates the need that we need more work on this area to know, okay, how can we really improve the treatment for these women?
Absolutely. Well, I just want to say thank you very much for presenting your work and giving us insights into maybe how Rivaroxaban is being prescribed and some of the outcomes in a fairly sizable registry population. I really appreciated hearing from you and especially having that pharmacist voice come through. So thank you so much. I know that our viewers are going to want to read more about this, and so they can go to our website, rpth.isth.org. And personally, Victoria, I want to say best of luck with your PhD defense, and I hope that we see more of your work in RPTH in the future. Thank you to everyone for watching, and keep an eye out for our next RPTH recap.